So while we have a definition of concussion that implicates pathophysiological processes and biomechanics, we still diagnose concussions based on observable signs and self-reported symptoms because there is not yet any evidence of what the biomarker would be, and that's a significant area of need. To try to deal with that in the current setting, it's clear in the research that people use multiple approaches to concussion diagnosis, and we think that's a good thing, although, again, without actually knowing what the biomechanical and biological markers are, it's difficult. But a multimodal assessment, including neurocognition, balance, and symptoms, seems to be a reasonable approach and is encouraged. Further, the evidence is pretty clear that while the brain is recovering from concussion, it's much more susceptible to secondary injury that could be worse, and in some cases lethal, although there's very little evidence, small numbers of cases of what's called second impact syndrome. So we still don't know a whole lot about that. But getting a second concussion while recovering from the first does appear to result in a more significant injury that takes longer to recover. So removal from play is an obvious common sense principle that we encourage and seems to show up in most of the newer state laws. While physical and mental rest is a common sense approach to managing concussions, there are not yet any controlled clinical trials for that or any other treatment for concussion. So this is an area that needs considerably more work. And while most people will recover without any sort of medical intervention, on the order of 90% will recover within 2 weeks, there is a 10 to 20% group that do not recover, and we don't know a whole lot about who those are. And in fact, in the literature, there continues to be kind of evidence that there's a small number of people within the larger group studies who have much worse outcomes, and trying to drill down into those individuals and discover what is unique about them is another area for further research. There's, as I said, there's little empirical evidence for the psychosocial treatments, so one of our important recommendations is that we start to look at clinical trials for what does work and what doesn't work. And recommendation number 2 is that the National Institutes of Health and the Department of Defense should support research first to establish objective, sensitive, and specific metrics and markers of concussion diagnosis, prognosis, and recovery in youth. And secondly, that this research should inform the creation of age-specific evidence-based guidelines for the management of short and long-term sequelae of concussion in youth. In terms of short and long-term consequence of concussion, the evidence is that people who have a number of concussions are more susceptible to another concussion of more serious outcome. So the more you get, the worse it is. And so keeping those numbers low seems to be an important concept to keep in mind. The length of time between concussions is also probably a critical factor that is not well studied at this point. There is no data to evaluate the relationship between concussion and risk of suicide and depression in young athletes. We need more data to determine whether repetitive head impacts and multiple concussions sustained in youth increases the risk for later conditions such as chronic traumatic encephalopathy and or Alzheimer's disease. We just don't have the connection from youth concussion to, say, older athletes yet. So we further recommend that the National Institutes of Health and the Department of Defense should conduct controlled, longitudinal, and large-scale studies to assess short and long-term cognitive, emotional, behavioral, neurobiological, and neuropathological consequences of concussion and repetitive head impacts over the lifespan.
Thank you.